I want to take a moment for all of us just to recognize the residents for these projects that they're about to present to us, and really think about how impressive it is that this is done with the context of the fact that is very obvious and often forgotten, that this is all done as a resident, right? Where your primary goal is to hone your clinical acumen and your surgical skills and your bedside manner, which is already, a big undertaking in a span of just 4 years. So a big congratulations and thank you to the residents, their support people, and their mentors for all the additional time and effort that goes into making these projects possible. A lot of which happens, we all know, on nights and weekends, outside of the context of duty hours. To the residents, as you know, it would be my dream to make every single one of you a clinician scientist that produces scholarly work for the rest of your career. But I know that is only one path. And just because it's my path doesn't mean it needs to be everybody's path. But at the very least, what I really hope that you have gotten out of this experience with your resident project is a better understanding of how this kind of work is produced and disseminated, which will really make you, a better consumer of medical literature, will allow you to really thoughtfully incorporate findings into clinical work or advocacy care, and ultimately inspire you to engage in critique, like we heard earlier this morning. I'm going to just wrap this up because we've got lots of really great presentations to go through and not that much time. You'll see that our residents have really produced work that covers the breadth of research interests and reflects their own personal passions. So we have projects that are large population level prospective studies, single center studies looking at very rich and granular data, qualitative work focusing on marginalized populations, projects examining quality improvement measures, and then work that really focuses on medical education and physician wellness. So congratulations again to our graduating residents, and we will get started with our first presentation. I think Dr. Huang is going to give the first intro.
Well, good morning, everyone. It's a true pleasure to be here today at Resident Research Day. And congratulations to all the chiefs for just not only surviving your clinical schedule, but doing this. As Dr. Sobhani said, I always feel like between the long shifts and the occasional sleep deprivation, doing research really requires dedication, and some may say a slight disregard for personal free time. But in all seriousness, as evident from Dr. Safran's talk, intellectual curiosity is really what drives our field forward, and asking why and participating is an important trait as a physician. So today I have the great privilege of introducing Dr. Brady Magaoay, who will be presenting our work on fibroid prevalence. And over the years, Brady has shown not only a keen interest in research, but he is dependable, pleasant, and a great team member. And his contributions span reproductive health, fertility, as well as advocacy. And he approaches every project that he's taken on with enthusiasm. We're incredibly fortunate that he'll be joining our division as an REI fellow for the next few years. I have no doubt that he'll make a lasting impact to our division, department, and most importantly, our patients. So please join me in giving Dr. Magaoay a warm and perhaps caffeinated welcome for his talk today. Thank you.
Good morning, everyone. I am Brady Magaoay. I'm one of the chief residents. Thank you all for coming. I also wanted to just celebrate my mentor, Dr. David Huang, for being awarded the Exceptional Physician Award this year. So a round of applause for him. I think he remains a good example of what happens here, where you can stay here forever. So big shoes to follow. The title of the project we worked on was The Presence of Fibroids in Transvaginal Ultrasonography in a community-based diverse cohort of 996 reproductive-age female participants. So here's a quick lay of the land of what OB-GYNs are talking about today, which is the background significance of our project, the objective, the methods, results, discussion, and conclusions. So just a quick background. This is common knowledge for most of the people here, but leiomyomas or fibroids are the most common neoplasms affecting female patients. And they are composed of monoclonal roots muscle cells, as well as fibrous connective tissue. And although these are benign, they can be a common cause of morbidity for many of our patients. We think of fibroids causing heavy menstrual bleeding, leading to anemia, bulk symptoms causing pain. And with all of these different symptoms, this leads to increased outpatient appointments, emergency visits, as well as some more invasive procedures. And looking broadly at how fibroids affects the healthcare system, there are about 30,000 myomectomies that are done each year, and about 37% of all benign hysterectomies are due to fibroid-indicated causes. And just looking at the cost, both direct and indirect costs have shown that fibroids lead to about $5.9 to $34.4 billion annually. So beyond patient care, this is also heavily influencing our healthcare costs. And so what do we know about fibroids? Most of the studies that have been done are on Black and white patient populations, primarily patients with symptoms who have already gone treatment. And as many of us can account the literature and from personal experience that the burden of fibroids is grossly disproportionately affecting patients of color, specifically Black women. And so what are the knowledge gaps that we are seeing? Much of what we don't know is what is the prevalence of fibroids in the Hispanic or Latinx population, as well as the Asian population. And furthermore, what are the prevalence of fibroids for those without symptoms? And so with this sort of dearth of knowledge came our project, which was to address this gap in knowledge about the fibroid prevalence and distribution in the US, as well as to estimate the proportion of individuals with fibroids in this more diverse, non-clinical, and community-based cohort of reproductive-aged female patients. And so we conducted a cross-sectional study of patients that came in and had a transvaginal ultrasound by one of two board-certified reproductive endocrinologists. And we were looking at the presence of fibroids, the multiplicity of fibroids, as well as the different dimensions of fibroids for patients. And these patients were recruited through the UCSF Ovarian Aging Study, which is a community-based cohort, again, reproductive age. And these are patients that weren't seeking any reproductive care or any medical care in this study. And so we were able to recruit a rather equal distribution of participants in this study in 4 different racial ethnic backgrounds. So there was an arm of patients that were white, another cohort of Black or African American, another cohort of Hispanic, Latinx, as well as an Asian, specifically Chinese identifying patients or participants, excuse me. And in this inclusion criteria, patients reported regular menses, were not exposed to any medications containing progestin or estrogen within 3 months of participating in the study, as well as no history of ovarian or uterine surgery. And so this is a long list of all of the great statistical analyses that we had done. We did ANOVA and chi-square tests to look at the racial and ethnic groups, as well as the demographic information that we collected amongst our participants, as well as use these same tests to look at the parameters of fibroid burden and more intricate univariable logistic regression, as well as multivariable analysis to evaluate the association between race, ethnicity, as well as the private presence, as well as to try and control for any other factors that were associated for fibroids, which we'll go into with more in the results section. And so for table 1, I just wanted to start at the top right-hand corner and just show you that there were 996 participants in this study. And if you continue to look at that first row, you can see that about a quarter of the group came from each of the 4 different groups. So rather equal distribution of the 4 arms of the study, or the 4 groups in the study. As we move down on this table and we look at the median mean age, it was about 35 years old. And again, when you look at that same row, the mean age in these different groups are also around the age of 35. When we look at some of the more other demographic information about our participants, we can see that patients with the greatest BMI were seen in the Black African American population. Those with the greatest number of people that were smoking during the study were seen in the white participant population. And in regards to nulliparous status, we see that the majority of participants in the white and Asian population were nulliparous. And in regards to just education, we see that there was the lowest amount of participants receiving a college degree in the Latinx or Hispanic population. And in this figure here, I just kind of wanted to show you the trend of the number of fibroids in the different age groups for each of the populations that we studied. So the age groups were divided into 5-year age groups. And the trend that we can see here in the Black or African American population is that as age increased, the prevalence of fibroids also increased. And you can see this similar pattern in the Asian or Chinese population here in the yellow stars. When we're looking at the fibroid characteristics in the study, the first underlying number value in this table shows that about 20% of all participants in the study had fibroids. And as we go down the table, you see that the group with the highest prevalence of fibroids or presence with fibroids, which too much of not our surprise, was in the Black or African American population that we have here, followed by the Asian population was about 21.8%, and in the white and Hispanic population was 12.7, followed by 10.7. Moving down on the table, we looked at, of all these participants, how many of them had more than one fibroid. And again, if you look at that column in regards to the Black or African American participants, there were more participants in the Black arm or African American study arm with multiple fibroids than the other groups. However, there weren't any sort of significant differences amongst the different groups from our study. And then when we look at the size of the fibroids, we see that the larger fibroids were seen in, again, the Black African American population compared to other arms. And this was statistically significantly greater in size compared to the Asian as well as the Hispanic population groups. And so when we do these multivariable analyses as well as linear regression analyses, when we're just looking at race itself, we see that in the top line, race continues to be, at least for the African American Black population, race is associated with a higher odds ratio of having fibroids. And when you make these adjustments, continuing along that red line, when age is adjusted, is when you adjust for other things in the demographic table. So if you think back to table 1, when you're looking at smoking, obesity, and previous parity, it shows that race and ethnicity still continues to be a factor with a higher odds ratio of having fibroids. This is also similar in the Asian American cohort, where race ethnicity continues to be part or more highly associated with having fibroids. And so from the data that we collected, this was an extrapolated sort of probability of fibroids for these 4 different ethnic groups within the nation. And without surprise, we can see from the table from previous data that we would see higher probability of fibroids in the African American as well as Chinese population. Another thing that I didn't really mention was that with age, above the age of 35, there's also a higher odds ratio of having fibroids. And so in discussion, just to kind of summarize everything that's happened, we were able to provide a a study that was a large study, community-based cohort of, again, reproductive age participants from different racial and ethnic backgrounds. And we were able to see that older age, as well as race and ethnicity, were significantly associated with increased odds for presence of fibroids. And much of our data is in concert with previously reported data about the sort of the burden of fibroids that affect people that are African American and Black. What's sort of novel to our study is that we were able to see that Asian, specifically Chinese participants were also disproportionately affected with fibroids when you compare them to white participants. And what we were able to also see is that the Hispanic or Latinx population had a rather similar burden of fibroids when you compare it to the white population. And across all age groups, as you kind of think of that table, the African American as well as Chinese populations had higher prevalence of fibroids at all age groups compared to the other white and Hispanic Latinx population. And so when we think of this data, how do we kind of apply it to the pathophysiology of fibroids, and how do we relate that sort of to the race ethnicity that we're seeing here? And I think what our study shows that it's very multifactorial pathophysiology of fibroids. One thing we think about is that fibroids are hormonal responsive and estrogen driven. And so there's genetic polymorphisms, as well as other data that shows that uterine responsiveness to estrogen has been shown to be greater in Black as well as Chinese or Asian populations, which might help explain why we see these higher prevalence of fibroids in these two groups. But then when you kind of look at more granular information about the multiplicity of fibroids, which is much greater in the African American and Chinese population, again, this notion, singular notion of hormonal responsiveness cannot or doesn't necessarily explain the difference in the multiplicity of fibroids. And then when we looked at increased BMI, if you think back to the first table where BMI was greatest in the African American population, we know that with increased BMI, you have decreased sex hormone binding globulin, hyperinsulinemia, which creates this milieu that might be more favorable for fibroid development. But again, this can kind of maybe just explain what happens in the African American population, but not necessarily the Chinese population, which was actually the opposite, where they had the lowest BMI in our study. Other things that we think of that might cause increased fibroids in the African American population is the presence of phthalates, which were higher in previous studies in African American studies, which can lead to fibroid, or rather decreased apoptosis of fibroids. So I think this still remains a great area of research and study to kind of understand fibroid pathophysiology. And in conclusion, just to summarize, again, the study that we've done and just looking at the hard numbers that we collected in our study, we saw that 35.7% of the African-American or Black participants had fibroids, followed by the 21.8% of Chinese participants in our study, which was much greater than the 12.7% of Hispanic or Latinx participants with fibroids. And lastly, the lowest number of prevalence of fibroids were seen in the white participants was 10.7. And I think this study is just meant to both enlighten both physicians as well as patients to be aware of what might be causing some of the symptoms that we commonly see in both the OB and GYN, and ensuring that we are both all collectively looking for timely interventions and management and treatments. And I think an area of study specifically in my interest would be kind of to identify specific fibroid characteristics and their impact on adverse reproductive outcomes in individuals. So thank you again for your time and attention. Yes, Dr. Sabana.
Presentation. I will just put a caveat in here that I'm no longer a gynecologist. My understanding of fibroid burden is that it typically comes from folks who are symptomatic, right? They have pain or bleeding or whatever else it is. And it seems like in this population, these are sort of screening transvaginal ultrasounds done. Have there been any data collected for these patients sort of longitudinally about whether they develop symptoms? Because is there a burden of fibroids if you just sort of are incidentally identified to have them, but you never developed any symptoms or requiring therapy or surgery.
No, that's a great question. There is data about these patients. If we look back into the greater study, which is the OBA study, which is a longitudinal study. So we could go back and kind of look back to see if what happened to these patients. Did they get any other management treatments? Or did they get symptomatic from these fibroids eventually? I think of in terms of fibroids, they might have maybe more subclinical effects on patients. So other things that I think about in like GYN is that fibroids can decrease or make it less favorable for implantation. Other things I think on like the obstetrical side is like malpresentation of fetus, preterm labor, or those who had gotten surgery for fibroids, how that affects their birthing plans. But I think that's another sort of next step for this project is to look at what happened to these patients. Yeah. Yes, Dr. Rowan.
This was fabulous. I have a question that, there's so much in the research world now. Data came out of the US. Since your study looks really at Asian Chinese specifically, I'm just curious how the data out of China might be looking at what you might find if you look for a fibroid prevalence in that population.
Yeah, I forgot that we have an online audience. And so Dr. Owen was just asking how our data compares to fibroid data coming out of China. I think that's a great question. I haven't necessarily looked at the data from China, but it's definitely, I think of that, at least the Chinese population there would be potentially more homogeneous and have greater controls for different variables than we are controlling here potentially. But definitely another part to look at for future research. Yes, Dr. Jackson.
That was a great study. Thank you for sharing. I'm always curious about how we define race, especially with our current thinking around race being a social construct, and especially with your Asian and Hispanic population. So were they self-identified, and it looks like you collected within like at least the Asian population, like subcategories of Asian.
I believe in the study, both parents from the participants had to identify as that race. So I was looking that up too because it changes. Yeah, it's changing, and I think it's very important to identify how these identifications are made for the patients and how can we apply them.
Especially if we're going to use genetics as a reason. So it's the same thing with the Black patients then, both patients.
Both parents of the patient. Yes. Yeah.
Right.
Yeah.
Interesting. Yeah. Thank you.
Hello, my name is April Bell. I'm an assistant professor in the Department of Family and Community Medicine here at UCSF. I'm also the director of the Girls Lab, where we conduct youth-powered research to improve the lives of Black women and girls. And I'm honored to have served as the faculty advisor for Dr. Bria Peacock's research project. I'm also delighted to have the opportunity to tell you more about her. I'm getting over a cold. I'm not contagious anymore, but I sound a little weird. Dr. Bria Peacock is a trailblazing physician, advocate, and scholar committed to reproductive justice, health equity, and the empowerment of young Black parents. She currently serves as the Advocacy Chief Resident in the OBGYN here at UCSF, where she educates and encourages systemic advocacy among her colleagues. As the first resident ever selected as the UCSF Bixby Center for Global Reproductive Health Advocacy Fellow, and one of the first to be selected as an emerging scholar in family planning by the Society of Family Planning, Dr. Peacock is reshaping conversations around reproductive autonomy, particularly for Black adolescents navigating pregnancy outcomes in the South. She also holds a leadership position as the co-chair of the Advocacy Special Interest Group at the Society of Family Planning. Raised as a Black woman in the South, Dr. Peacock was the first in her family to be born and raised in Atlanta, Georgia, although her roots run deep in Cordell, Georgia, where 5 generations of her family have endured and thrived. Growing up, She bore witness to the policing of Black bodies and the systemic disparities in reproductive health care, particularly for young people who choose to parent. This experience ignited her lifelong mission to dismantle oppressive systems, amplify marginalized voices, and ensure reproductive justice not just an idea, but a reality. While still a first-year medical student, Dr. Peacock took action. She founded CLA Augusta, now Choices Within Reach, an organization providing community, financial resources, and tangible support for young Black parents in Augusta, Georgia. For the past 8 years, while completing rigorous medical training, she has remained at the forefront of this advocacy, disrupting stigma, empowering young parents, and challenging the structures that marginalize reproductive choices. Her voice and expertise have been sought after by major media outlets, including CNN, the New England Journal of Medicine, the SF Examiner, and the LA Times. In 2021, she received the US Surgeon General and US Public Health Service Excellence in Public Health Award. Then in 2022, she was honored by Stanford University's Michelle R. Clayman Institute for Gender Research for her groundbreaking work. She has also influenced policy, testifying in support of legislation signed into law by Governor Newsom in 2023 that expands access to abortion training for out-of-state residents, an effort she undertook, and you all will understand this post-call, underscoring her unwavering dedication to the cause. Dr. Peacock's ultimate mission is clear: to return to the South and transform the landscape of reproductive health by dismantling systems that restrict choice, reframing narratives that shame young people's choices, and creating spaces that celebrate Black joy and reclaim our freedoms. This August, she will take the next step in that mission as the Complex Family Planning Fellow at Emory University. Today, she is here to share the innovative research that she has led over the past few years, research that challenges assumptions, highlights disparities, and most importantly, centers the lived experience of young Black parents. Dr. Peacock.
Good morning, everyone. Thank you for being here. Thank you for being in attendance. And thank you, Dr. Bell, for such a great introduction. I appreciate that. My study was called Beyond the Decision. I barely had any support at all. It's a study that explores the young Black women's pregnancy experiences across 2 states. And if you know me, you know which states those are. Georgia and California. I want to thank my research team who is listed here. So what do we know? We know that pregnancy decisions are shaped by the intersection of personal and social factors, but we don't really know how these factors influence the reproductive choices for young Black women. And why this population is important is because we know that young Black women face disproportionate barriers to reproductive health care. So without targeting our research, without targeting our solutions, we allow systemic inequities to persist, continuing to limit this population's autonomy and access. So our objective was to explain how family dynamics, personal values, and community attitudes towards pregnancy options influence not only the initial decision-making process for this population, but also the following parenting experiences among young Black women in 2 very different geographical and political landscapes. So in order to do this, we conducted semi-structured interviews, 9 of those, for young Black women ages 17 to 24 who were currently pregnant or had experienced pregnancy in their adolescence. 4 of those were from California and 5 were from Georgia. These interviews were auto-recorded and transcribed, then coded independently by 5 researchers. We then conducted a thematic analysis to pull out key themes in the interviews and used Deduce software to help us with that analysis. This study was done over a course of 4 months between July 2022 and July 2023 and October 2023. So one of the key findings is that geographic disparities do exist in reproductive health counseling between these 2 locations. In California, abortion was discussed readily by healthcare providers and community members alike. One participant noting it as more so information. However, also in California, some participants felt pressured towards abortion, citing the Black maternal health crisis, with one participant saying, "My doctor encouraged me to get an abortion because being Black, we have a higher death rate giving abortion." In contrast, in Georgia, abortion was rarely discussed by providers, and a lot of the information, sometimes misinformation, came from family and community members. One participant said, "My auntie taught me abortion was not an option. She said it would mess up my body," for example. Other things we noted was that there's significant gaps in young pregnant women's healthcare, including the lack of continuity when thinking about the gap between pediatrics and obstetrics for these patients. One participant noted, my pediatrician, when they found out I lost my virginity, she didn't talk to me about none of that. It was like, "I can't help you as far as that. You have to go to a different doctor now." And she didn't have an exact OB then, so she went to the health department. Other participants felt dehumanized, asking doctors to be more open and have bedside manners, treating them as humans and not just a job. Some participants also noted the effects of age bias, feeling like they were told they were overreacting if they brought up concerns and they weren't listened to. We also saw that race concordant healthcare is crucial for this population, with many participants citing feeling more comfortable and being able to relate to providers that look like them. Another key finding and what was reoccurring is that there was not very much structured parenting information for this population. One participant noted that she couldn't find any parenting class to try to prepare her for parenthood. So a lot of the participants went to TikTok and social media to find information. And the information that was noted in clinics and on brochures and things of that sort, they felt like it was not enough information to actually prepare them for what pregnancy, parenthood, and postpartum would be like. We also noted that family relations were very significant in the pregnancy experiences of these young people, with some having strong family support, with family members helping to navigate their prenatal care, while others felt abandoned by family and friends, having words of excitement during the pregnancy, but once the baby is born, those words were not met with tangible actions and assistance from their family members. This family and community influence continued to reign true in the pregnancy decision-making for this population, with one participant in Georgia saying, "My parents have always told me, you get pregnant, you're keeping it. It's just like, well, you know what? I might as well go ahead and deal with it. Go ahead and follow it and see it through." Another major factor was relationship status. So these participants thinking about if they didn't want to do this and navigate this pregnancy on their own. So if their partner was not on board with the pregnancy, that strongly influenced what they decided to do with the pregnancy. And then other participants noted personal goals or economic stability. One participant saying she already had a plan. She was fresh out of high school and thinking that, should I go on and do the path that I was destined for? Or do I stop in my tracks right now and take care of a child? So all of these factors were influential in the pregnancy decision-making for this population. Other things that we discussed or that we found is that young Black mothers after birth reflected on the support or the lack thereof of support from community programs, their partners, and families, and how that affected their experience. One participant noted, "I think CLA Augusta is the only program that helped me stay out of depression and actually become excited about being a mom, even though at first I didn't have much support." Another participant noted how the lack of family support led to a consistent struggle, having to call into her job because she didn't have consistent childcare and not being able to actually have the funds for her necessities. Another participant thanked their partner for being different and stepping up, sticking beside her during this parenthood journey and being the good father that she never had. So in conclusion, geographic, racial, and socioeconomic factors create not only distinct decision-making context for young Black women navigating pregnancy, but significantly influence their pregnancy and postpartum experiences. So my call to action for this group of folks is to hire and retain Black providers to improve culturally responsive care, to expand culturally competent healthcare, ensuring that reproductive counseling and pregnancy options counseling includes all options without coercion or stigma, and to strengthen social support systems by either creating programs or funding and supporting programs that already exist that convert the empty words of help into actual tangible assistance for young Black women during pregnancy and early parenthood. Addressing these gaps is the first step to bridging the gaps, and it's critical to continue to improve reproductive health outcomes and supporting young Black women in pregnancy and beyond. And with that, I thank you. And I'll open it up for questions.
Hi, Dr.
Thank
Fantastic work.
Thank you.
And I have two questions. One, a brief one. Well, one is just, can you explain in more detail how you recruited folks? And then the second question relates to your very thoughtful conclusions and implications. What would, in response to these findings, what would culturally responsive care look like as opposed to just responsive?
Yeah.
What makes it culturally responsive?
Yeah, I love that question. We're on Zoom, right? I have to repeat. Okay. Dr. Sefrin asked two questions. The first was, how did we recruit these participants? Obviously in Georgia, I have many connections there through my organization, and through the organization, my former med school, we put up flyers throughout the community of Augusta and Atlanta to recruit participants there. And then California, Dr. Aisha Mays of the Dream Youth Clinic does a lot of youth work here and also put up flyers in her prospective clinics here in Oakland, California. And then as far as culturally responsive care, it's extremely important in my context and my life's work to reclaim our freedoms. And I think it's important to think about when the South is free, we are all free. And so my experiences as a young Black woman raised in the South is not the same as a young Black woman here in California for a lot of different reasons. So understanding those factors, that's what I mean about culturally responsive healthcare. And therefore we can actually give the appropriate amount of advice and kind of guidance to the people that come into our clinics. What else? Any other questions? No? Okay.
Hello, everyone. So I have the pleasure actually to present Isabel Wayenko. She is truly, truly impressive. I mean, she did her undergrad at Stanford, subsequently went to Harvard to get a master's in public policy, and then subsequently medical school at Harvard. And then we were lucky enough to recruit her for residency. And now she will be staying with us for fellowship. We're very lucky to have her in maternal fetal medicine. Isabel also has worked at the United Nations with she spent like a year there at a project for every woman, every child. She's been doing research in all areas, including policy. And when she was at Harvard, was working on work around sexual harassment, around medical training. And now she's focusing a little bit more on basic sciences and looking at different etiologies of fetal anemia, and specifically monogenic etiology. So I'm very excited to hear, and it's been a pleasure to work with her. And I have no doubt she will make major contributions to our field in maternal fetal medicine. Thank you for that.
Thank you for the kind introduction. I'm really profoundly grateful to be here and to be able to continue learning to be here in fellowship as well. I'll be discussing monogenic etiologies at risk for fetal anemia. Here's a brief outline for today's presentation. Let's just begin with a background of fetal anemia: screening, diagnosis, treatment. Fetal hemoglobin, or fetal anemia, refers to a hemoglobin value less than 2 standard deviations below the mean. We can think of fetal anemia in terms of both hemoglobin and hematocrit. And a term that we're familiar with in thinking about fetal anemia, on the L&D floor at least, seeing these results, would be multiples of the median. That is, we think of severity of fetal anemia in terms of how many multiples below the median does a fetal hemoglobin fall. And this standard median increases with increasing gestational age. And this figure shows the reference range for fetal hemoglobin as increasing with gestational age. But what are the signs that we would see indicating fetal anemia? We may see fetal effusions, such as fluid collections around the heart, the lung, the abdomen with ascites, under the skin. And if on prenatal ultrasounds we see even one of these effusions, that should prompt a full diagnosis for further evaluation. Specifically, this should prompt evaluation with MCA Doppler. Our suspicion for fetal anemia is already very high if we see at least one effusion, and we can then proceed to non-invasive screening for anemia through middle cerebral artery Doppler testing. In fetuses with anemia, the MCA peak systolic flow appears to increase above the normal range because of decreased blood viscosity, and increased cardiac output associated with anemia. We adjust for variation of changes in gestational age with 1.5 multiples of the mean as the standard indicator for fetal anemia. And with such a clinical picture, at least one fetal effusion with or without elevated MCA Doppler, we would then recommend invasive testing. Fetal anemia can be diagnosed with sampling of the fetal blood through percutaneous umbilical blood sampling, or PUBS, which we as residents often see on the L&D procedure schedule but aren't as familiar with yet. A needle is inserted into the umbilical vein and used to sample the blood to evaluate for whether the fetal hemoglobin's multiples below the median. This is sometimes paired with an intrauterine transfusion, or IUT, of red blood cells from a donor to the fetus. And genetic testing can also be performed through sampling of the amniotic fluid, or amniocentesis, most often done between 16 to 22-ish weeks of pregnancy, but can really be done up to 40 weeks. This is in comparison to chorionic villus sampling, or CVS, which can be done from 10 to 13 weeks and 6 days, which is sometimes no longer an option by the time that we detect even the first effusion, which is most often at the 18 to 22 week routine anatomy scan. When we see a case of one or more fetal effusions, this is an SMFM bulletin algorithm that guides our workup. We can proceed from initial findings of an effusion to non-invasive screening with the MCA Doppler, and subsequently to diagnostic testing with fetal blood sampling, and to genetic testing, often with amnios. But if after proceeding through this algorithm, we don't yet have an etiology for the fetal anemia, we could then proceed to sequencing. And when thinking about fetal anemia, perhaps what we're most familiar with is Rh alloimmunization. Certainly from the resident perspective, it's very routine for us to think about whether a fetus is indicated for ROGAM. And we're very familiar with infectious etiologies for fetal anemia, like reviewing torch infections. And nowadays, it's actually becoming increasingly important to think about infectious etiologies because of the increased resurgence of both parvovirus and syphilis. There are, however, multiple inherited diseases that can risk development of fetal anemia, and that's what we're focusing on today. Although we think about alloimmunization as one of the most common causes, it's important to think about cases that go beyond standardized testing and look into genetic explanations for why fetal hemoglobin or fetal anemia can occur. Many of these have monogenic single gene etiologies, and there's much more to understand. So specifically, the objective of this study is to describe the frequency and breadth of single gene etiologies that present with at least one fetal effusion, sometimes full non-immune hydrops fetalis that place the fetus at risk of developing anemia. And long-term with this research, by identifying these etiologies, we can think about targeted counseling and interventions. Methodologically, this study was a retrospective secondary analysis of pregnancies that were presenting with any fetal effusion who underwent fetal sequencing, either genome or exome sequencing. It was a multi-center study, and we opened up enrollment nationally with cases from 2018 to 2014. Cases presenting with a fetal phenotype of 1 or any effusion were eligible for inclusion into the pool that underwent sequencing, and findings of a pathogenic or likely pathogenic variant of a genetic disease known to be associated with anemia were included as a suspected single gene etiology. All sonograms were reviewed by an MFM or a radiologist. And the primary outcome asked, what's the frequency of monogenic etiologies presenting with fetal effusions at risk for developing fetal anemia? Secondarily, we were focused on describing the spectrum of monogenic disorders associated with fetal effusions that risk developing fetal anemia, and also describing the perinatal characteristics, including the initial prenatal presentation, the interventions, and the neonatal and delivery outcomes. Ultimately, out of a cohort of 350 cases, we identified 11 cases of prenatally diagnosed single gene disorders presenting with any effusion. That's about 3.1% of the study population. Let's review the secondary outcome of describing the prenatal characteristics. I have key cases divided across 2 slides here just to be a little bit easier to read. And to identify some of the important findings, many of these cases were detected around the first time of routine ultrasound, with only 2 cases being detected earlier at 12 and 14 weeks. There was significant variability in the phenotypic findings, ranging from a single effusion to full hydrops fetalis. And just to note on some of these findings, polyhydramnios is not technically an effusion, but an interesting finding that we see commonly. And then cystic hygroma is also not technically an effusion, but can be a presenting feature in these cases. Elevated MCA Doppler was seen in most cases, or 8 out of 11, and 2 cases resulted in IUFD, 3 chose termination, and 6 survived through hospital discharge. IUT was performed on 5 of these. And to expand on the 11 cases that we identified, we found really excellent breadth in the variety of monogenic etiologies. So let's discuss those in a little more detail. When we think about the steps of red blood cell synthesis, there are many stages where genetic variation can be introduced that subsequently introduces risk into normal erythropoiesis. And this was really reflected in the findings of the different disorders that introduced higher risk for an effusion or hydrops. Pathogenic and likely pathogenic variants were identified in both bone marrow abnormalities as well as red cell structural abnormalities. Oops. Specifically, variants were identified in the RPL11 gene, leading to Diamond-Blackfan anemia, as well as rare variants in the MECOM gene. This leads to generalized bone marrow failure with radioulnar synostosis and a megakaryocytic thrombocytopenia, as well as the ALAS2 gene that can lead to sideroblastic anemia. Variants were also identified leading to erythrocyte abnormalities, including the HBA2 gene leading to alpha-thal, PAZ01 gene that can lead to dehydrated hereditary stomatocytosis, as well as a variant in the HGB2 gene that codes for the gamma globin of fetal hemoglobin. And just to note, early in the development of the fetus, there's remodeling of both the venous and lymphatic systems that the complex interplay can basically lead to phenotypes that present with both red cell abnormalities and lymphatic abnormalities. Let's consider a few of these variants in more detail, starting with one of the more familiar diagnoses, alpha thal. This affects erythrocyte structure. 3 patients were found to have variants in their HbA1 and HbA2 genes with fetuses that developed effusions. As a brief review, alpha thal is related to deletions or mutations of the alpha globin gene that codes for the alpha chain of the hemoglobin molecule. And presence of 3 or more of these deletions or mutations can lead to hemolytic anemia or full hydrops fetalis if there are 4. Presentations in these cases included hydrops, cystic hygroma, thickened placenta, and then various cardiac abnormalities. And 3 out of 3 of these cases elected for no intervention, 2 elected for termination, 1 resulted in IUFT. Another more familiar disease would be Diamond-Blackfan anemia, a bone marrow failure disease. 1 case had a variant in RPL11, which ultimately disrupts ribosomal function and erythrocyte production. Presentation included actually a single fetal effusion with disc edema, and then findings of cystic hygroma, polyhydramnios, as well as cardiac findings. IUT was attempted in this case, but unsuccessful, and this case resulted in a live birth. And finally, we can consider dehydrated hereditary stomatocytosis. 4 cases were identified with variants in the PAZ01 gene. This affects the calcium channel of RBCs, and a gain of function mutation will result in abnormal dehydrated RBCs. Their presentations included ascites, skin edema, pleural effusions, pericardial effusions, polyhydramnios, and then various cardiac findings as well. 2 cases elected for IUT, and 4 of 4 cases resulted in live births. In conclusion, one of the most significant implications clinically of this research is that there are a variety of genetic conditions that place a fetus at risk for anemia, although not all may develop anemia. The study also points to intrinsic limitations in our current definitions of non-immune hydrops fetalis, which requires at least 2 effusions. But given the variety of presentations we saw with fetuses in these referrals, this underscores that really if in prenatal screening we see even 1 effusion detected, we should engage in a full workup for hydrops fetalis with timely referral to a center of expertise. And then diagnosis of pathogenic or likely pathogenic variants can really lead to more structured counseling, screening, and if needed, early intervention for future pregnancies for these patients. All of these cases were referred to UCSF for genetic testing with an ongoing research study available. And so we can also consider the goal for broader availability of diagnostic genetic testing in the future. And if we had more tailored counseling that also currently has just variable availability, then that can also be more helpful to patients. Interestingly, these patients presented with at least 1 fetal effusion, sometimes meeting criteria for hydrops, not always being associated with elevated MCA Dopplers. And the diagnosis was made with PUBs. This emphasizes the utility of considering PUBs also for diagnostic purposes, regardless of MCA Doppler findings if suspicion is high. And finally, when I think about clinical indications that we might see for these inherited conditions in routine prenatal care that we might think about well before fetal effusions even start to show, an example that comes to mind would be if on our maternal CBCs that we get routinely, we saw microcytic anemia. We're very used to considering iron deficiency anemia, and we're even anticipating, calculating how much iron supplementation we should give. But if a patient did present with microcytic anemia, we should still have a high suspicion for other etiologies, and they could even have a joint diagnosis of iron deficiency anemia and alpha thal. In consideration of strengths and limitations, first we can talk about strengths. A significant strength of this study is that we're at an institution that has access to genome and exome sequencing through our research programs. and that allows these conditions to be identified at all. We were able to identify a good breadth of conditions, and through these referred cases with which we had longitudinal follow-up from initial presentation, access to their detailed phenotypic data, from first signs of fetal anemia, data on interventions, data on outcomes, we really could follow like the full scope of what happens with these pregnancies. And finally, for a study on fetal effusions, this is actually quite a large cohort with multi-center referrals from across the United States. In terms of limitations, one limitation is that it likely underrepresents alpha thalassemia. Patients who have 3 mutations or variations in their alpha globin gene, this would result in hemoglobin H rather than full hemoglobin BARTs, and these were likely not referred to sequencing, so we can suspect that the monogenic etiologies for fetal effusions is actually higher than the 3% we found. And then, as mentioned, genome and exome sequencing may not be available in all clinical settings, and certainly coverage is variable for reimbursing genetic sequencing. Finally, for future directions, we do need dedicated research that can demonstrate the clinical utility of having sequencing be more broadly available in order to diagnose these conditions at all. We saw in this research that even just among the 11 cases, there was such a variety in initial fetal presentations, and we need to learn more about what these prenatal phenotypes are like. They can be associated with conditions that we don't yet even know are associated with fetal anemia. And finally, how do we best make a diagnosis and support these pregnancies? There is increasing understanding that if, for example, with something as severe as alpha thal with early IUTs, perhaps the outcomes for these fetuses can be more favorable. And so we need to better understand the most appropriate management and counseling for these types of pregnancies. Of course, I'd like to thank this incredible group at UCSF MFM who have been incredibly generous with their time and guidance, and I could not be more grateful to continue learning from them. Here are today's references, and we can now open for discussion. Dr. Huang.
That's an amazing talk. Some of the genes that on the carrier screen. So what's the current in terms of care and carrier screening?
Agree that we can kind of have an increased suspicion based on prenatal carrier screens. Certainly with, I guess the easiest would be to talk about like alpha thal. If we consider patients that we have a high suspicion going in. But some of these cases are also still kind of being learned and more obscure, and so would not necessarily be available readily on kind of what we think about as routine carrier screening.
Some of the genes on this carrier screen, so we don't in terms of access to care. Genes we also don't know what their penetrance is and carry it to manifest in fusion.
Yeah, I realized I didn't repeat the question. The question was for the genes that were detected that are also available on carrier screen, how can this help influence management? And that's true, actually, at least one of these cases came in for earlier ultrasound because of both parents were known carriers. Dr. Oversee.
How often are these, all of these cases first like unexplained fetal anemia, or do they undergo MSs? Or do any of these also have other multifactorial, like they also have RH present?
For these cases, they were all diagnosed through the through like further genetic testing.
Well, it's my honor and privilege to introduce Dr. Amy Ransohoff. A California native, Amy earned her Bachelor's of Arts with distinction in human biology from Stanford University. She had a brief stint working for the Obama administration in the White House internship program. Luckily, she came to UCSF for medical school where she excelled, and we were exceptionally fortunate to match her with us. In residency, we've witnessed similar excellence throughout her training, exceptional commitment and skill in clinical care, medical education, and quality improvement. Some highlights of her impact here include being one of 5 residents in the entire system to be recognized with the UCSF Teaching Excellence Award for cherished house staff, initiating an effort to improve our antibiotic stewardship in our own department. Yay! And serving as the QI senior resident, supporting our 2 QI initiatives at San Francisco General Hospital and UCSF Health. In the words of her peers, Dr. Ransohoff exemplifies what it means to be a leader. She's a great teacher and takes any opportunity, no matter how small, to share knowledge she has gained with her co-residents. She's phenomenal with patients and models excellent communication, even in the most difficult of circumstances. I so hope that she stays here with us for more time. Lucky for us, she will be. Dr. Ransohoff will be joining our department as faculty in OBGYN, and we'll have the great fortune of calling her our colleague and continuing to learn from her. Dr. Ransohoff.
Hi, everybody. So thanks, Dr. Whetstone, for that introduction. My research project over the course of residency was born from my interest in medical education. And it was a multi-institution endeavor. The other authors here, I'm grateful to all of them. And for time's sake, I won't read through everyone's name, but you might recognize some of them. I have nothing to disclose. And the learning objectives today mirror the objectives of our research project and the questions that we had. Our project aims to identify common challenges facing administrative chief residents across the nation. And considering program directors' perspectives and perceptions of the admin chief role, and then reimagine or look into alternative formats of the admin chief role, especially thinking about how other specialties like internal medicine do this, where instead of having the onus be on a current resident, rather offloading some of that onto a post-graduation position, which, like I said, is common in other specialties like internal medicine. And how would that go over in OBGYN? So before we get to background, quick raise of hands here. Raise your hand if you are or were a admin chief in your residency program. All right, look around. Thank you for your service. And I think we can all agree that admin chiefs do play a vital role in the programs. And they have a lot of work that they undertake, specifically the administrative burden of their role in the wake of COVID. And covering for a lot more absences than before has been an ongoing challenge. And in the medical education literature, there's a lot of data about other specialties, admin chiefs, again, mainly coming from the internal medicine world, but not really any on OBGYN admin chiefs. So we conducted a voluntary anonymous survey. It was national to all ACGME accredited programs in the United States, asking admin chiefs and program directors to fill out our survey. And we performed just descriptive statistics. And we had a overall pretty good response rate of about a third for program directors. So 94 program directors responded, mainly from academic institutions, though a good portion of community-based programs as well. And we had 93 admin chiefs respond, and we did compensate the admin chiefs, which I think likely helped with them finding the time to answer our questions. So first, just what do admin chiefs do? What are these residents across the country telling us they're doing with their time? Likely no surprise, the vast majority are spending most of their time on scheduling. About half reported at least 8 hours a week of administrative scheduling related tasks, and about a quarter reported more than 9 hours of their week, in addition to their clinical duties, just working on scheduling. And only 3% reported any clinical coverage for like having less clinical responsibilities in order to do these jobs. Those wondering about compensation, 80% were compensated, though that ranged from $400 for the entire year to $5,000 for the entire year. The average was $1,700 for the entire year. So we wanted to focus on what was most stressful, and probably not a surprise, unexpected absence coverage was the most stressful aspect of the job, followed by the weekend and holiday call schedule, mediating conflicts between faculty and residents, and then making the giant year-long rotation schedule and finding coverage for planned absences like conferences and vacation. How do admin chiefs feel about it? About half had an overall positive experience, and only 7%, this was, I think, surprising to me, only 7% reported a negative experience. Though, if asked whether they would do it again, if given the option, if they could go back in time, about a quarter said no. Most reported a negative impact on personal well-being and the ability to be productive in research. And the average stress level was 6 out of 10 with a standard deviation of 1.5. But I do want to point out here that a lot of people did derive positive value from this role, despite it being stressful, mainly in leadership skills. So pulling some quotes from the qualitative part of our survey, while I found it very rewarding, it's extremely time consuming and did take away from time I could have spent doing more clinical work, studying, or living my life outside of residency. And they didn't want to miss clinical opportunities in order to do the admin work. This is from an admin chief. I did not want to be an admin chief to begin with. Overall, it's a thankless position that gets stuck doing work that no one else wants to do and wrapped up as an honor or a leadership experience. A lot of people pointed to conflicts amongst residents being incredibly stressful and feeling really underappreciated. What did program directors say? So program directors did correctly assess what the problem was. They were mainly aware that the admin chiefs were primarily doing scheduling, despite the role historically being seen as one of like leadership development and really an honor and a way to advocate for residents. Ultimately, what it ended up being was administrative burden of scheduling. They didn't think of anything else they wanted the admin chiefs to be doing. They said that they're doing enough. And interestingly, we asked program directors about trends, and this was a national theme that in the last 5 years, 76% of program directors said that they were seeing increased need for coverage due to illnesses like COVID. And then I think there was some people talked about how after COVID, there's been more need for illness coverage, probably because people are taking being sick more seriously and asking for being absent when they're feeling ill, and absences for personal well-being going up by about 61% noticed by program directors. There's also a national shift in the last 5 years reported by program directors for a decreased willingness to cover other resident shifts. So one program director said that there's escalating expectations for someone other than residents to cover resident absences, which has caused tension. So we are noticing that there's a problem of a high admin burden on current residents who have taken on this role. It's become stressful and the burden is becoming higher over the years. So we wanted to know what people would think of a different model, one that's post-graduation, a PGY5 basically position like internal medicine does, where some of this would get taken on by that role instead in a hybrid with clinical practice. The proposed model in this survey was 40 hours a week, 60% clinical, 40% admin, and there would still be someone, a current resident, to help with urgent scheduling needs. So this is what we proposed, and we wanted to see if people would do it. So if compensated as a PGY5, which is what a lot of specialties like internal medicine do, 10% of admin chiefs said that they would be interested in taking on that role. About 60% of PDs thought it was interesting. But if that was more compensated closely to a new faculty salary, that changed to about 2/3 of admin chiefs would consider that role, and a similar amount of program directors said that they would support it. There were some interesting comments from admin chiefs saying that they would really only consider this position if there was some sort of benefit in the form of marketable skills. Another admin chief said they would never delay their placement in a practice of like full-time clinical practice to do this role, and they worried about actually being able to contain the admin responsibilities to 40% of the job. A program director mentioned that they questioned the impact of having 40% of your time being admin, allowing for enough OR time to keep your clinical skills up. Others were worried that the funding of just a PGY5 salary would take advantage of residents. Other people thought that it would be difficult to recruit for, but were interested. And another program director said that they loved this idea, they've thought about it themselves, and that they would ideally provide some clinical experience and skill building to launch a career in academics. So our takeaways from this study were that admin chiefs are experiencing a significant burden of stress, mainly due to their scheduling responsibilities, and that has gotten worse in a post-COVID world. Program directors have also acknowledged this demand, and this decreased willingness to cover other people's shifts over the last few years has also made coverage more tense and challenging. And there might be potential interest in changing how we go about this and creating some sort of hybrid of clinical work and administrative work that alleviates some of this burden off of residents who are ultimately still trainees finishing residency, and onto someone who's been hired for the position in a hybrid role. So here are some of the resources that we used for our study. And again, thanks to my research team, and I'm happy to answer questions. Dr. Jajiri.
I was wondering, you use internal medicine a lot as a do you know the model of like
Yeah, that's a great question. The question was, I'm comparing this a lot to internal medicine, partially because that's where the most medical education literature comes from related to this. But the question was about other procedural or surgical fields and how what their setup is. And it depends, but many of them adopt a similar one to ours, though some have 5 admin chiefs in their class. So it really depends. But yes, we are certainly not alone in our specialty of how we do this. Dr. Song.
I may have missed this, but the people, the admin chiefs you've surveyed, are they current admin chiefs? Were they all?
Who was interviewed or who was surveyed? Admin chiefs from 2022 to 2023. Mm-hmm. Mm-hmm. Yes. Dr. Sabani.
Some of the suggestions that have been made are mostly just pushing the burden to a different individual. Right? Yeah. So I think the second bullet point that you have in terms of the takeaway, are there any sort of ideas of how to address that, right? Because that contributes to the burden, regardless of who's responsible for filling in the scheduling.
Yeah, the question is, are there other thoughts about how to improve this situation other than just sort of moving the burden onto a different person? That is an excellent challenge and question in, I think, nationally in most programs, and thinking about how we can change our systems to match the change in culture within residency in general. I don't know how much more time we have, so I think I'll stop here. Thank you.
All right. Hi, everybody. I'm Ariana Cassidy. I'm an MFM here, and I'm incredibly honored today to introduce Dr. Jasmine Correa. I'm just going to read a little bit because it's hard to remember all of her incredible accomplishments. But Dr. Correa received her BS in neurobiology with interdisciplinary honors at the University of Washington. And then she received her MD at UC Riverside, supported by a very prestigious merit-based mission scholarship. And a review of her accomplishments just demonstrates a very consistent dedication to service, mentorship, and advocacy. We met early on in her residency, and she demonstrated some interest in Accreta research. And I said, great, there's a database that is empty. And she was one of just a handful of residents who built the entire thing and published a paper. She was a co-author on that. That wasn't enough. She wanted to do more, and she's going to present some of her research today on some of our pathologic findings and how we counsel our patients about it. And she also, this is a small slice of what she's accomplished. She has been an award-winning creator of surgical videos. I hope you all were in attendance at her grand round. Anyway, we're so incredibly proud of her. She's clinically a superstar and also just demonstrates commitment to her true north of serving her patients at home. And she's going back to UC Riverside to be a MIG surgeon. So take it away. Hi, good morning, everyone. Let me just set this up quickly. Okay, thank you, Dr. Cassidy, for that wonderful introduction. Just to give a little background of how a MIG surgeon got interested in Accreta. It's a little maximally invasive, but I was, kind of remembering my medical student experience as a third year when I was rounding on antepartum patients for about 3 weeks, and had a young Latina patient, grew up in the same community as me, with a concern for an Accreta, even per Accreta, and was rounding on her daily, grew very fond of her, and she was also incarcerated. So she was shackled to her bed every day until she had a disastrous hemorrhage and barely survived her emergent cesarean hysterectomy overnight. It made me realize kind of the disparities that we have in our centers of excellence and kind of like who benefits from them and who gets access to those centers of excellence. And we only had one gyn-onc on call to do her surgery. So my community desperately needs complex pelvic surgeons, and that's what I'm gonna go do. So here we are. My project is called Evaluation of Single Site Practices for Documenting and Follow-up of Delivered Placentas with Pathologic Accreta-Related Diagnosis. And my mentors are Dr. Cassidy and Dr. Raven. So just a little background. We have to get into semantics because we throw around Accreta a lot, but what do the pathologists actually look at? So placenta accreta is related to the differing levels of abnormal placentation in a hysterectomy specimen. We can't say this with our delivered placentas, but we do say it. So we need to be very clear on the words we are using. Less is known about the clinical significance of what is called basal plate myometrial fibers, or BPMF. And this is what we're seeing of the abnormal histologic myometrial smooth muscle fibers that are attached to the basal plate of a delivered placenta. And this can be with or without intervening decidual layer. So just showing you kind of our placental biology here and the H&E staining. So this is a hysterectomy placental, a hysterectomy specimen. So we see this normal division between the muscle and the decidua. And then we have here placenta accreta where that layer is kind of distorted, and we don't see that anymore because it's invading. So this is what we see on delivered placenta specimens, or what we call BPMF. So in slide A here, there is no myometrial fibers, and we can just see the basal plate is pretty clear and delivered normally off of the uterine side of the pathology here. And here we have stage 1 of the BPMF, which has some myometrial fibers here, but still some intervening decidua. And then stage C, which is considered like stage 2, is there is less decidua. And then here's a zoomed in version of stage 2 where you see the smooth muscle fibers here and like one cell layer of decidua. So this is still BPMF because it's on a delivered placenta specimen. And so BPMF has an extremely wide incidence range from 0.9 to 40%, but this is truly because there's like limited data on what this is, and like the training for pathologists is so widely variable. And if you guys know of like how the pathologists actually sample the delivered placenta, they only get like 3 biopsies of like random sites. Sometimes if we tag it for them, it makes it easier, but it's just very elusive sometimes. So that's why there's a wide incidence range. However, it is important because there are newer studies coming out that seeing BPMF on an index pregnancy can indicate increased risk of developing placenta accreta in subsequent pregnancies. Currently, our institution, when we have an accreta-related pathologic finding on a delivered placenta, these are labeled as BPMF, microscopic accreta, focal accreta, placenta accreta. They have all these names on the actual pathology report, but we can't really tell the difference between all of them. They're all kind of within the same of we see these abnormal muscle fibers on the basal plate of the placenta. And we don't have a standardized protocol for documenting and following up these results. So the primary objective of this study was to evaluate our current practices for documenting these reports and how we're following up with patients. Our questions are, how are accreta-related diagnoses being documented and followed up? Are there any demographic or intrapartum differences among these patients with and without follow-up? And among those with an accreta-related diagnosis, what are the outcomes of subsequent pregnancies? So this was a retrospective chart review from March 2015 to January 2023. We picked this time period because this is where pathologists had improved awareness of what identifying BPMF was like. Our inclusion criteria were delivered placentas with an accreta-related diagnosis, and we excluded any cesarean hysterectomy samples. We completed this project under our current UCSF MAPS IRB and basically created a separate red cap to just include folks with BPMF. And so the primary outcome is, how are these pathology reports being documented in the EMR? How are they being followed up? Are there differences in folks who have follow-up versus those who don't? And other secondary outcomes that we looked at is, what was the indication that the placenta was sent to pathology? What were the subsequent pregnancy outcomes? And then do we have data of the placental reports of those subsequent pregnancies? So here's some baseline characteristics. We had a total N of 102 delivered placental pathology reports that had accreta-related diagnosis. The median age was about 37. 52 of these patients were nulliparous. 41 had used some form of ART for their index pregnancy. 68 had some type of prior uterine instrumentation, which included C-section, first trimester DNC, postpartum DNC, myomectomies, or hysteroscopic operative hysteroscopy. And then 35 of these patients had some documented like uterine pathology as well. In terms of the pregnancy outcomes for these patients, 25 of them had like some prenatal risks for developing PAS. So it's documented in their problem list as like they had extra workup, an extra ultrasound, maybe even an MRI. 63 of these patients delivered via C-section, 39 had vaginal deliveries, and 82 of them had postpartum complications, being retained placenta or hemorrhage. And then kind of looking at our secondary outcome here, indication for placental pathology, the most common with 63 of them being retained placenta. And they kind of varied all over the place of why we were sending these placentas to pathology in the first place. In terms of how were these placental results documented, 38 of them only had the pathology report. So no one documented about them or kind of identified them. 46 had some sort of documentation in the EMR, either someone like put it as a problem on their problem list or in their history tab. And then 54 of these results had some kind of documentation in a provider's note. So how are we actually communicating with our patients about these pathology results? I would like to highlight here, 43 of them there was no communication with the patients regarding these results. 36 had a postpartum visit, either with their like prenatal provider, midwife, someone in the postpartum time. And it was interesting to see what was done with this information, because we really don't know what to do with this information. Some folks were then referred to MFM. Some folks were told to just be aware of it for your next pregnancy. You may need an extra ultrasound. And some folks were even recommended to get an ultrasound within the immediate like 4 to 6 week postpartum period, just to make sure they didn't have retained placenta. 29 had an MFM visit, 12 were documented as a phone call, and 16 had some type of direct communication via like a secure chat message with the patient. So then kind of looking at the differences between folks who did have follow-up and those who didn't, just highlighting here that majority of folks with documented follow-up did use some form of ART for their index pregnancy, and then a majority of folks also had some kind of documented uterine pathology. In terms of intrapartum differences, pregnancy outcomes, those who had follow-up more likely to have postpartum complications such as retained placenta and hemorrhage. And then now looking kind of at our secondary outcomes of what happened in subsequent pregnancies, we only had, of the 102, only had some information about 21 individuals who then went on to have a subsequent pregnancy. Of those subsequent pregnancies, 7 had NSVDs, 9 had cesarean sections, and 3 had a cesarean hysterectomy in their subsequent pregnancy. 13 of these had pregnancy complications such as preterm delivery, adherent placenta, and hemorrhage. And then in terms of the subsequent placental pathology results, unfortunately, 10 of those weren't available, mostly because a lot of these folks delivered at different institutions and I didn't have that data available. But one of them was described as microscopic PAS, 4 had placenta accreta, and 6 had no evidence of PAS. Basically, the placenta delivered pretty easily and nothing was seen on pathology that was concerning. Of the 3 that had cesarean hysterectomy, 1 was a focal accreta and the other 2 were placental accreta with 99% invasion, and the other one had 75% invasion of the myometrium. So in discussion, summarizing kind of what we found, majority of placentas with accreta-related diagnosis were sent to pathology secondary to retained placenta. 37% of these pathology reports did not have any documentation besides the pathology report itself, and 42% of the results were not followed up with patients. Those with follow-up were more likely to have utilized ART for pregnancy, have known uterine pathology, and have postpartum complications such as retained placenta and hemorrhage. Of the available placental pathology reports from subsequent deliveries, 6 placentas had no pathologic abnormality, while 5 placentas did demonstrate accreta-related diagnosis. So some strengths, this is the first review of current practices at UCSF for documentation and follow-up of these Accreta-related diagnosis. And we've now have created a REDCap database for ongoing investigation of outcomes in subsequent pregnancies of folks who have BPMF in their index pregnancy. The limitations are interesting because it is a sampling bias. We have really limited data on BPMF, therefore not all pathologists are placenta experts or trained to kind of review the nuances in these diagnoses. So it can be challenging into determining what is the clinical significance of these results. Should we be looking at these results at all? Like, what are the costs to healthcare? And are we having folks then undergo extra workup, MRIs, in their subsequent pregnancies? So documentation and follow-up at our center is inconsistent. This can lead to quality improvement measures needed to standardize follow-up regarding these pathology results. And more recently, Dr. Cassidy has created an Accreta-specific high-risk clinic to provide follow-up and counseling regarding future pregnancies. And as shown in prior studies, specifically last year, Baylor published a study showing that BPMF being incorporated into predictor models can improve antenatal diagnosis of PAS in subsequent pregnancies, but we still need future data to understand what the significance of this pathologic finding is. And these are my references. I'll open it up to discussion. Open it up to questions. Yes, Dr. Wright.
Comment or question on the ART versus cesarean. It seems like ART is a bigger risk for PAS than
Cesarean section, yeah. And that's kind of what's been incorporated in these newer studies regarding BPMF is that specifically IVF does have a higher risk is seen in more folks who have higher risk for PAS development. In the Baylor study that I mentioned, the hazard ratio is about 1.3 for IVF, and then it was 14 for having BPMF in the index pregnancy. So it's quite interesting. Yes.
Joey, I'm one of the REI faculty.
Hi. Yeah.
Great presentation. Yeah. I think that's interesting because some of the questions regarding that is, did these patients have a history of myomectomy? Do they have Asher's?
Yeah.
Is it IVF in and of itself, or is it predisposing health conditions that led to their infertility?
100%. Yeah.
When we talk to patients about this, it's like they see that headline, but
yeah.
There's some nuances of
yeah, I didn't parse the data that way, but it's totally right. Folks who had IVF were more likely to have a bunch of DNCs early on in their life, or just have some type of instrumentation of their uterus, which I think is another important factor that we as OBGYNs need to focus on. We need to be very mindful of how we're instrumenting uteruses at what point. The decidua is so fragile in the postpartum period that even when we're manually taking out these placentas, there is damage being done. So it's an important thing to highlight that there's multiple risk factors that cross over. Yes, Dr. Fergie.
It's a very interesting point. I was wondering if anybody has looked at people that have had DNC, what their rate of getting versus what people have had the DNCs and all of those things, and I.
Got it. Okay. I'll look it up. Yes. Yes, Dr. Light-Olson.
I want to pick your brain on the patients who didn't get any follow-up.
Yeah.
I'm about the systems issues at play because I think about how vulnerable people are in this current period, and they miss their appointments and they get rescheduled at the resident clinic, and I see they have a retained placenta, and I've never looked at a path report, and now I'm wondering how vulnerable these patients are going forward, and what is our system of flagging these path reports and routing them to the actual provider that's going to see them face to face.
Yeah.
We're talking about UCSF here, and I know that continuity clinic of the general is even more complicated. And so anyway, I'm just wondering how do we actually get this information?
I think we need to start off with meeting with our pathology colleagues and being how is this diagnosis being made? Because it seems pretty inconsistent that we can call something a focal accreta versus BPMF. I think we need some clarity of this is how we are going to standardize how we're doing these diagnoses. So at least the report is pretty consistent amongst all our patients. And then, yeah, unfortunately, even when those results come up, it's not flagged, like it's not routed to the provider. It really was so interesting to see how different pathologists kind of went out of their way to email the ordering provider saying like, hey, I just finished reviewing your patient specimen, like this is our findings, but that's not the expectation. I think we need to kind of like sit down with our pathology colleagues and figure out a way of standardizing this, the follow-up. But then the bottom line is like, what is the clinical impact? Like we don't have that data yet to kind of set all these things in motion. So, and another complex part of that is we are a tertiary care center. So a lot of these folks went back to their communities and therefore do not have follow-up with us. So no one will ever look at their placenta report, unfortunately. Yes. Oh, okay. Where's that?
Oh, this testing. Hi, everybody. I'm Nagma Faruqi, one of the generalists in the Department of OBGYN here. And it is with pleasure and excitement that I would like to introduce Dr. Jessica Gamerl. I am not her faculty advisor for the project, but I'm very emotionally involved in this project, as everybody knows, and hence very excited to be here presenting to her what is very much needed in our unit. I'm also very proud of her exceptional growth as a resident through our department. One of my best memories of Jessica and working on the unit is she and I saw 23 patients in one day in triage. And not only did she keep smiling through all of it, despite me, but she also gave me timely notes, which is phenomenal. And at that point, I knew exactly that she was going to be okay in this specialty. Well, there you go. You were well trained, and God wanted that. Jessica received her Master's of Science from the University of Nebraska Medical Center and a medical doctorate from Oakland University William Beaumont School of Medicine. Dr. Gamerl came to us from New York as a second-year resident. As she calls herself, she was orphaned at that point from that program. And we are very happy to have adopted her and are extremely lucky that she chose us. She is has an exemplary commitment to patient care and advocacy for all of her patients. And I am very, very, very proud of you. You know that. She has accepted an OBGYN hospitalist fellowship at the University of Colorado and intends to pursue, and if that's not enough, she intends to pursue a fellowship in critical care after that. And I was just trying to convince her to come back after that, and we were interrupted, so we'll continue afterwards. But Jessica Gamerl.
I'd like to thank Dr. Faruqi for that very kind introduction and for her mentorship over the years. Hello, can you hear me? No. Oh. Can you hear me now? Yes. Okay. All right. Thank you, Dr. Faruqi, for that kind introduction and for your mentorship over the years. I will be talking about quality improvement projects here at UCSF, and most importantly, the timely AROM project that we've been working on. So this is a little bit of basic information for everybody, but that we're probably all very aware of, but induction of labor rates in the US have been steadily increasing over the last 40 years. And in the 1980s, they were utilized about 9% of the time. And in 2020, the rate was about 31%. And this is due to a lot of different factors that include chronic comorbidities of birthing patients, conditions of pregnancy that may require expedited delivery like preeclampsia on the rise, and then also elective inductions. So when considering induction of labor, particularly for nulliparous patients, inductions can be a very lengthy process. They are associated with higher costs and longer hospital stays, and they often require significant medical resources compared to patients who just come in spontaneous labor. And more importantly, we know that the longer someone is in labor, the more likely they are to need interventions and then to have adverse outcomes like intraamniotic infection, postpartum hemorrhage, and cesarean section. So there have been many studies looking at induction agents, including pharmaceutical and mechanical agents. And we know that utilizing prostaglandins with cervical balloons together is a very effective and efficient way to induce labor and achieve a delivery. Once the cervical balloon is removed, a common way to help continue the labor induction process is the artificial rupture of membranes, or AROM. However, the timing of when to perform an AROM varies by institutions, private practice, and then patient choice. We know that performing an amniotomy early rather than later can shorten induction length by hours, and a shorter time in labor leads to less adverse outcomes. And that link has been shown in multiple randomized control trials and meta-analyses, and ACOG recommends it in their clinical practice guideline number 8. So for those very reasons. And at UCSF last year, our OBGYN hospitalist fellow, Dr. Emily Navarrete, specifically collected data from our own labor and delivery unit, which you can see also demonstrated that timely AROM shortened induction times by about 6 hours here, and that there was no increased rate of adverse outcomes and a clinically significant reduction in postpartum hemorrhage rates for patients who received an AROM specifically within 1 hour of the cervical balloon being removed. So just some background for UCSF. About 50% of our inductions include, we induce about 50% of our patients here. Our NTSV induction of labor rate averages about 50%, but is kind of trending upward. And the reason for that is because we're a tertiary care center. Our patients have a lot of complex medical problems. Their fetuses can have very complex medical problems. And of course, elective induction rates continue to rise. And because we do so many inductions, we wanted to create a quality improvement initiative to improve our timely AROM rates in an effort to reduce induction times, as well as see if we can lower adverse outcomes. Since this could potentially have a wide impact on the patients that we care for here, it was really vital that we include everyone working on our unit in the shared goal of improved care and patient safety. So what our project did was look at all of our inductions for patients who were nulliparous and had term singleton vertex fetuses, also known as NTSV for our learners, and how often were we actually able to perform an amniotomy within 1 hour of cervical balloon expulsion or removal, to try and gauge what our rates were and increase them. We did not include multiparous patients in the study. We also did not include patients with multiples or patients who underwent outpatient cervical ripening and had their balloon come out at home. And our primary outcome and objective for this study was to see, one, if we could just increase our rates of timely AROM on our labor and delivery unit, and to see if that reduced labor times. And then we also wanted to look at secondary outcomes for adverse events like intra-amniotic infection, postpartum hemorrhage, and cesarean delivery, to see if timely AROM had any impact on this as well, compared to patients who were not given a timely AROM. And we collected this data through our EMR by utilizing charting data about cervical balloons and amniotomy that was documented by nursing, as well as individual chart review. And we also reviewed our data prior to initiation of this project. So this chart includes information about AROM data from January 2024 to June of 2024, and our initiative started in July of 2024. So as you can see, our timely AROM rate kind of ranged around 30%. And we specifically set a goal of trying to get to 50% with our timely AROM rates, because as we all know, there's a lot of factors that play into when you can safely AROM somebody or perform an amniotomy. And we also want to honor patient choice in this as well, because some patients, that is not part of their birth plan, and we want to honor that. So we began discussing ways to improve our timely AROM rate, and we started introducing multiple interventions. Some of these interventions focused on education about amniotomy for patients and staff, making providers on the unit just more aware of the concept of timely amniotomy, and then encouraging consistency about the evidence-based data to support AROM for our providers and our patients. Just a kind of a brief summary, in August, we announced the project to our leadership and at our nurse council meeting, where we were able to identify some project champions for the outpatient and inpatient settings. Shortly after, in September, the project was announced to residents during the start of their rotation blocks, describing the goal of the project and encouraging them to find opportunities for timely AROM. In October, we had more reminders sent out in the weekly resident newsletter where residents are more likely to read it. And in December, we reviewed the language on patient-facing handouts that are given to patients when they arrive for their inductions. One of the challenges of doing quality improvement is that it requires implementing a lot of changes and changing culture and attitudes. And I think overall, this project was really well received by our nursing colleagues, our residents, and our providers. And there was a lot of interest and enthusiasm regarding this project. So this is what we found. Our AROM rate has been steadily increasing. We're at about 35% now, and we're really hoping that we'll meet that 50% goal or close to it. And then this is just a kind of zoomed in version of that chart. The yellow line shows the initiation of the project as well as sort of our baseline data from before we started. And then specific interventions that were done. This is not all inclusive. We had many, many meetings with our nursing colleagues through our clinical practice council, nurse council, and OB quality committee meetings that are not really listed here because they were so ongoing and continuous. But a lot of these things were specifically designed to raise awareness and educate about the project. So, and then these results are just showing some preliminary data as we're still collecting information, but we did appear to shorten our induction lengths for patients with timely amniotomies by about 5.5 hours. And then our secondary outcomes really didn't show an increase in any adverse event, but notably there was an absolute difference of about 11% in interamniotic infection for these patients. This has not been statistically analyzed yet, but we plan to do that with the next steps. And so this is really exciting, and we're looking forward to seeing what sort of clinical and statistical significance is shown. And then I guess I'll just start off the discussion. So to summarize our findings, we've seen a steady improvement in our timely AROM rates, and we're getting closer and closer to our goal of 50%. And the preliminary data does show that patients who undergo a timely AROM have a shorter induction length by about 5.5 hours compared to those who didn't. And it also doesn't appear to show an increased risk of adverse outcomes. These findings are consistent with the broader literature surrounding timely AROM and its use in inductions of labor. But one of the limitations of this study is its sample size, but also that it heavily relies on accurate charting and documentation, which can vary widely where we can put this information in the chart. And so some of these events may not be adequately or accurately captured. And floor acuity also impacts that as well. So the next steps of this project include continuing to collect more data about this, continuing to encourage all of our colleagues to continue monitoring for timely AROM, and then analyzing our secondary outcomes. But one thing that this project has led to is a lively discussion about cord prolapse rates. So we are looking into this. We're going to analyze some of our cord prolapse data, and we're going to talk about this with our nursing colleagues, and I'm going to be doing a literature review on it to kind of go over what does the evidence show about cord prolapse, and then bring that to all of you and our nursing staff. We also plan to implement more interventions like distributing our data to the doula committee and sharing it with our patients once we have more solid data. So I'd like to thank Dr. Rosenstein for mentoring me through this project, and Dr. Amy Ransohoff for her support and guidance, as well as Dr. Tatsis and Dr. Lamar, who are our project champions, and Cynthia Blatt, our lovely data analyst, as well as our outstanding labor and delivery nurses, who we would not have been able to do this initiative without their interest and continued engagement and incredible dedication to patient care. And lastly, I'd like to thank all of my co-residents for putting up with my emails and listening to me and your dedication for this project. And I'd also like to thank all of my co-chiefs for your continued support and acceptance over the last 2.5 years. You never made me feel any different, and I love you all. Do it. Anything?
I want to say something.
Yes, Dr. Freeman.
appreciate this project on labor and delivery. As the director of the birth center, 5 hours, I'll take it. I think it's close to 6 hours right now. I'm watching very closely. Everybody's mental state and everything, but the main thing is we're seeing less hemorrhage. And the choreo rates do not increase because we AROM somebody. And the cord prolapse, let me just tell you. But there is a discussion and we will take care of that. Can't happen anywhere. So, but I'm very grateful for this project. Let's keep it going. Let's momentum build. Thank you.
So for those listening on Zoom, Dr. Furky pointed out that some of the internal data that we're seeing does show a decrease in postpartum hemorrhage rates and no increase in interamniotic infection. And so she's very excited about what this project will continue to show. Dr.
Hi,
Yes.
great presentation.
Dr. Cleveland.
I'm curious, I find myself citing this study often around transplantation, and I'm curious if there's any issues with materials, like similar to that checklist that they get for induction. It could be, we work to include parts of the reasons why we recommend these interventions.
Yes. So the question was, what are some of the things that we have planned for this project when it comes to patient-facing education, counseling, and materials that we give them? And so one of the interventions that we did in December was that we specifically looked at the induction checklist that we give to patients when they arrive to the unit. And it is consistent with our recommendation of a timely amniotomy. It actually says less than 30 minutes of Foley balloon expulsion, but sometimes, you know, that doesn't happen. And we've also been trying to think of ways that we could provide more education around induction and the reasonings for each intervention in the prenatal visits. And Dr. Lamar has been one of the champions for that. And we're going to be working with her to see if there's anything that we could provide in sort of the packets that the patients are given. But I also think there's going to be a more emphasis on consistent language and how we counsel patients about this. And one of the ways that we are thinking about or talking about with nursing leadership is maybe our triage nurses could call patients the day before and just kind of review the expectations for inductions and answer any questions that the patients have now that it's kind of looming and become more real. Yes, Dr. Hannah Ladles.
Do you think that have you noticed any change in the conversation with only having 30 cc balloons? Because we're now asking to AROM patients at smaller dilations, and I think that that's something might feel more uncomfortable to others, and even though we might feel that it's feasible and well applied. So do you think that that is part of the conversation? Balloons are coming out earlier.
So the question was, does the use of the 30 cc full cervical balloon, is that impacting our ability to safely AROM patients? And we haven't looked at that. I think that's something that we can talk about, especially since the 60 cc balloon seems to not be easy to get, and it's now backdated. Yeah, it's back. It's back. Okay, so we can see, but hopefully it's back, baby.
Okay, now for my second presentation. No, I'm just kidding. I'm here to introduce my dear friend, Dr. Chrissy Freeman, who was born and raised in Memphis, Tennessee. Her interest in becoming an OBGYN, y'all, I'm country, I'm sorry, was piqued in high school when she watched her older sister battle preeclampsia while pregnant with her first niece. She attended Washington University in St. Louis as a pre-medical student, majoring in anthropology and minoring in dance. After undergrad, she moved back home and worked as a high school science teacher with Teach for America. She later matriculated to Emory University School of Medicine in the greatest city in the land, Atlanta, Georgia, where she graduated magna cum laude and was heavily involved with curricular development and increasing supportive structures for underrepresented students within the medical school. Dr. Freeman has developed a specific interest in the experiences of Black people and people from underrepresented communities in medicine, both as patients and as providers. Over the last 4 years, her scholarly works have included an investigation into the relationship between neighborhood deprivation and the incidence of maternal morbidity, which you will hear about today. A report on the virtual interview of experiences of Black and Brown residency applicants, as well as the creation and success of a novel mentorship program for URM medical students called Emory Impact, all of which have been published in peer-reviewed journals. Here at UCSF, Dr. Freeman's commitment to education and mentorship has been very clear. She's received a special distinction in medical education resident teaching award from UCSF medical students in 2022. In this academic year, she served as education chief resident and advocated for increased attention to career preparation and mentorship, specifically for OBGYN residents not applying to fellowship. Dr. Freeman has been a featured speaker on numerous national stages, including the Student National Medical Association's annual Medical Education Conference, the Elevate Med Explosion of a Dream fundraiser and Scholars Summit, and on the Therapy for Black Girls podcast. Dr. Freeman takes great pride in being an advocate for herself, her patients, and her peers, values equity, truth, and justice in all that she does. To begin the next phase of her journey, Dr. Freeman has accepted a faculty position in the greatest city in the land in the Division of General Obstetrics and Gynecology at Emory University. I'm glad to have her with me. I'm so proud of all that she has accomplished in her early career and can't wait to see the amazing work she will do next. After all, she is just getting started. Please join me in welcoming Dr. Chrissy Freeman.
Okay, hello everybody. I think this is the most important slide. I have no disclosures. My project is looking at severe maternal morbidity in a Medicaid-insured population in Atlanta, Georgia, specifically at Brady Memorial Hospital. So starting with some introduction, a lot of these things are things that we probably know, but we know that the United States has the highest pregnancy-related mortality ratio of any developed country, rising from 7 to 17 pregnancy-related deaths per 100,000 live births in the past 3 decades. In the US specifically, non-Hispanic Black women are 3 times more likely to experience maternal mortality than non-Hispanic white women, regardless of socioeconomic status and educational level. Black women with at least a college degree has a higher rate of maternal mortality than white women with less than a high school education. These national statistics are also evident in the great state of Georgia. Yes, Bria, it's great. Where over 42% of counties are maternity care deserts, which means that there is no obstetric provider, whether midwife or obstetrician, that is available to provide a pregnancy care. But maternal death is not the only factor of importance here. Severe maternal morbidity, or SMM, is defined as an unexpected outcome of a labor and delivery that results in a significantly short or long-term consequence to a woman's health. At Grady Memorial Hospital specifically, the rate of SMM was 795 per 10,000 live births between 2016 and 2018, representing an over 5-fold difference compared to the national rate of 147. So here's a little bit additional background about severe maternal morbidity and individual level or patient level factors associated with increased risk. Most notably being age less than 20 or greater than 35, self-pay or Medicaid coverage, lower socioeconomic status, and presence of comorbid medical conditions. Race and ethnicity is not a risk factor, but is associated with increased risk of severe maternal morbidity, including Black, Hispanic, American Indian, and Alaska Native. This disparity is multifactorial, and there have been many, many studies done to try to elucidate why this is happening, and we still have not gotten down to a very clear answer. So thinking about the neighborhood influence on maternal health, this was one of my biggest points of interest. We know that there's significant variety in the neighborhood context in which people are born, raised, and experience their lives. And there are many studies that have looked at the factors that influence people to have a higher risk of severe maternal morbidity. This first study from Australia and also in Canada showed that individuals from low socioeconomic status neighborhoods have higher risks of SMM. A study in New York proved that the highest rates of SMM were in neighborhoods with extreme racial and economic polarization. And there are also studies not related to maternal morbidity specifically, but also pregnancy outcomes that show that there's increased risk of preterm birth and low birth weight with increasing deprivation. So why does it matter where you live? We know that neighborhood characteristics are a result of contemporary and historic policies and processes, and individuals have been sorted into their neighborhoods through processes of racial and economic polarization. It is possible that observed differences in outcomes across neighborhoods may reflect the combination of present-day access to resources or the long-term results of historic racism and segregation. Regardless of the mechanism, neighborhood characteristics may indicate higher obstetric risk, allowing for tailoring of interventions or practice. And so our goal with this study was to understand whether neighborhood factors, such as neighborhood deprivation and neighborhood racial composition, serve as a marker for higher obstetric risk in a safety net hospital system in Atlanta, Georgia. For our study setting, we completed the study at Grady Memorial Hospital in Atlanta, Georgia. That is me as a cute little M3 on the rooftop of Grady Memorial Hospital. Grady is a large safety net hospital that has a mandate to serve Fulton and DeKalb counties. There are about 2,200 deliveries per year, and all patients are eligible for sliding scale care if they do not have insurance. One of the nice things about Grady is that there's a lot of non-medical support and referral services available for patients. So for example, in their prenatal clinics, it's very similar to our clinics at SFGH, where patients can get their work referrals and have kind of wraparound services there. Despite all of these interventions, the rate of SMM is over 5 times the national rate. For our data sources, we utilize the Grady Obstetrics and Gynecology Outcomes Database, or GOGO, which includes all deliveries greater than 20 weeks gestation, whether live or stillborn, that occurred at Grady Memorial Hospital. It's an EMR-based database, and there's inputs monthly. We looked at all deliveries at Grady between January 2011 and March 2020. We identified SMM using CDC indicators that matched to ICD-9 and 10 codes that included delivery and up to 42 days postpartum. And our primary analysis included all indicators of maternal morbidity, including blood transfusions, which we know typically drives SMM. For our individual level data, we use race, age, parity, insurance status, mode of delivery, chronic conditions, pregnancy complications, and zip code, all of which were available in the database. They were de-identified and extracted from GOGO. For the Neighborhood Deprivation Index, this is a marker or a tool that we use to represent the socio-contextual environment in which our patients live. We use data from the American Community Survey 5-year estimates, and then the Neighborhood Deprivation Index is actually derived from US Census Tract variables that look at the percentage of males in management and professional occupations, percentage of crowded housing, percentage of households in poverty, percentage of households with dependents with a female head, percentage of households receiving public assistance, percentage of households earning less than $30,000 per year, percentage of households earning less than a high school diploma, and percent unemployed. These are all markers for neighborhood and family resource availability. Looking at neighborhood racial composition, we also got this data from American Community Survey 5-year estimates. We looked at the percentage of neighborhood residents who identified as non-Hispanic Black, and we dichotomized this at 50% Black to signify either majority or non-majority Black neighborhoods. This is also a marker for historic and contemporary segregation within the city of Atlanta. This figure is not one that was used in our primary paper, but it was done in our preliminary analysis to determine whether or not there was enough variation in the level of neighborhood deprivation within the city of Atlanta and within our patient population. And it shows that there is. We use maternal zip code data from GOGO and match that to US Census tracts. And then we categorize this on a statewide basis and then narrowed it to the local space. So we defined neighborhoods into tertiles, or 3 of deprivation, so high, medium, and low. And then we narrowed those to the counties that our patients come from. So for the data analysis, we did multivariable low binomial regression to estimate relative risk of SMM by tertile distribution. There were lots of numbers and I got a lot of help in doing this part of the analysis, but we did account for all the individual level covariates that I previously mentioned, and then also neighborhood level confounders, including the neighborhood percent Black composition, food insecurity, and access to transportation, all of which were kind of condensed. So there were some, as far as access to transportation, we looked at like bus routes in different neighborhoods and different things. So for our sample size, there were 25,938 recorded deliveries in the time frame that we included. We excluded deliveries that were missing data on race or parity, and our final sample still had over 25,000 patients. For our table 1, there are lots of numbers here. I will focus on just a few. Approximately 24%, 32%, and 44% of our patients lived in the lowest, middle, and highest tertiles of neighborhood deprivation, respectively. Overall, 6.2% of patients experienced severe maternal morbidity at or following delivery. SMM risk was similar across all tertiles of deprivation at 5.9, 6.3, and 6.3%. The composition of patients varied by residents in low, medium, and high deprivation neighborhoods. A larger proportion of patients from neighborhoods in the highest deprivation tertile were non-Hispanic Black at 78.9% compared to 41% in the lowest tertile. And they were also teenagers, 12.7% versus 6.8% compared to patients from the lowest deprivation. Patients residing in the highest deprivation tertile had slightly higher rates of all hypertensive disorders, morbid obesity, and cesarean section compared to patients in the medium and lowest tertile. For our multivariable analysis, there was surprisingly no association between neighborhood deprivation and severe maternal morbidity in either of our models. So including the crude model, and then when we adjusted for individual and neighborhood factors. Residents in a majority Black neighborhood demonstrated a slightly higher risk of SMM in the crude analysis. There's a little typo here, with the relative risk being 1.2 and the confidence interval was 1.1 to 1.3. However, after adjusting for individual and neighborhood covariates, this association was attenuated to null. So for my conclusion and discussion, this was definitely an unexpected lack of association, especially based on prior studies that have been done. One of our questions is, does the relative homogeneity of the patient population at Grady and the communities that they come from affect these results? So we know that because Grady is a safety net hospital, it's in downtown Atlanta. This is the trauma center, so it's the level 1 trauma center in the state of Georgia. So there's a big catchment population. And so one of our questions to ourselves is whether that influenced the data or our outcomes. We also believe that neighborhood level social determinants may not be useful markers of risk in comparison to individual characteristics. I'm kind of getting into some of our limitations, but this was also a single institution study. And so one thing that I am very excited about is to return to the city of Atlanta and to Emory University to continue this work and possibly expand this across all of Emory University sites, not just Grady Memorial Hospital, but also multiple of the Emory satellite locations. I think it's important to identify and address modifiable individual and neighborhood level risk factors so that we can provide the best, most equitable care for our patients as possible. I think that's all I have. Yes. For my acknowledgements, I would like to thank the patients of Grady Memorial Hospital, specifically Black women, my research mentors, Dr. Cherie Boulay, Dr. Denise Jameson, and Dr. Kate Stanhope. I could not have done this work and gotten it published in the Journal of Maternal, Fetal, and Neonatal Medicine without them. I would also like to thank my life and career mentors, both here and abroad. Dr. Cherie Hill, Dr. Adina Davenport, and Dr. Tracy Henry are 3 incredible Black women that I have looked up to since I was a first-year medical student, and I'm so excited to join them as faculty at Emory in just a few short months. I would like to also thank Dr. Nagma Faruqi, Dr. Vicky Tatsis, and Dr. Stacy Young for being mentors of mine here. It's been a journey, and I'm so grateful for you. To my family and friends, especially the people who are pictured here, Dr. Buckner, Dr. Crook, Dr. Gandy, Dr. Peacock, y'all have been my family for, well, Aaron just got here, but also part of the family. Y'all have truly been my family and my support system throughout my time here, so I'm really grateful. Thank you. Dr. Cook.
Like even your see a difference between the legacy and higher education.
Yeah, so Dr. Cook's question was about, I'm going to try to summarize, the socioeconomic diversity of Black patients in the city of Atlanta, and how that may have factored into our results. I think it's interesting because the population at Grady is mostly uninsured or Medicaid, and so my speculation is that patients with higher socioeconomic status are not utilizing Grady as their primary access site for medical care, which is why I think it would really be interesting to expand to Emory's more private sites. So Emory University Hospital in Midtown, Emory main campus, Emory Decatur, which is where I'll be working, and see if we can, make better comparisons by looking at all those groups.
Excellent presentation, and I also liked how you worked through the unexpected results. I'm wondering if you can speak a little bit about how you decided what to use as a confounder versus a covariate effect modifiers, especially food insecurity. I mean, is that part of the index itself? So if you could just talk about what the implications are of how you choose your confounders.
So the question was about how confounders were chosen for this study. So this was actually the second iteration of this project. The first one, we did not actually use neighborhood racial composition as its own outcome necessarily. And so in the first analysis, neighborhood racial composition was the only thing that showed a differential level of maternal morbidity when using the neighborhood deprivation index. Other things that we were thinking about is that if you look at the US Census tract variables that go into the neighborhood deprivation index, it doesn't necessarily account for those things. Like, do people have access to transportation to get to their appointments? What is food availability looking like in those communities? And so those are things that we thought might also be influencing patients' reported rates of maternal morbidity based on, just their lived experiences in their neighborhoods.
I have the distinct honor of introducing Dr. Sadie Scott, who said, just say, this is Sadie. And maybe that is enough, but it also speaks to the fact that she doesn't like to be highlighted. She doesn't like to get the limelight, but you asking for that is going to make me give you the opposite. So here we go. So Dr. Scott is originally from LA. She completed her BA in integrative biology with a minor in African American studies at UC Berkeley. She went on to complete a postbac at UC Davis, and then she earned her medical degree at UCLA. While earning her MD, she spent an additional year earning her master's in public health with a concentration in maternal, child, and adolescent health at UC Berkeley. And while earning her master's, she joined fellows and faculty here at UCSF on exploring abortion attitudes and experiences of Black women. And that's when I first met the amazing Dr. Sadie Scott, who helped on a study that I was doing as a fellow. While earning her MD at UCLA, Dr. Scott also co-founded and directed the Minority Medical Alliance. She served on the board of Med Students for Choice as well. Dr. Scott was heavily recruited to UCSF for residency, and we are so lucky that she chose to join us here. She has been an all-star since she started. She has been a fearless leader, taking on the position of admin chief resident in the last year. It's just always fabulous to work with, and she just leads by example. And she's not that flashy, she's not that showy. She wanted me to say this is Sadie when we introduce her, but she's really amazing and deserves all the praise and honor for the work that she does. We will be sad to see her leave, but she is going to make a great impact as she's joining the faculty at Harbor UCLA next year. So with that, thank you, Dr. Sadie Scott.
I was doing both things at the same time. Just this. Okay. All right, perfect. Coordinate. Thank you. Okay. So my research topic is what's on their mind, exploring Black pregnant patients' perspective on labor pain management. So before jumping into the details of the study, it's imperative to review our history so we can better understand the hesitancies people may have with their engagement in medical care and practices. Even as early as 1844, Black enslaved women, specifically Anarcha, Betsy, and Lucy, were experimented on and underwent gynecologic surgeries without anesthesia and without consent. From 1909 to 1979, doctors performed over 60,000 forcible, unauthorized sterilizations. Those targeted were primarily immigrants, Latino women, Black women, and poor women. In 1979, California rescinded its sterilization laws. However, in 2006, coercive sterilization returned in the California prison system, in which about 150 female inmates were coerced and forced into signing while pregnant. This continued dehumanizing perception of Black people is still prevalent today. Even as recent as 2016, a study found that some medical students and doctors falsely believe there are biological differences in the amount of pain Black Americans experience compared with white Americans, which affected treatment recommendations. So as we can see, for numerous years throughout history, Black women did not have reproductive autonomy nor reproductive justice. More recently, several studies have found that Black pregnant individuals are less likely to receive an epidural for labor pain management. Some studies attributed this to access, insurance status, or just to race. One study highlighted that among women who were unsure about epidurals, women of color were more likely to face pressure to accept the epidural by hospital medical staff. Of those who received anesthesia, either during vaginal deliveries or via C-section, Black women were more likely to experience failure in their pain medication and were less likely to have their pain and anxiety taken seriously by doctors. Additionally, with Black women being less inclined to get the epidural, in the event of an emergency, they are more likely to undergo general anesthesia, which is associated with increased morbidity and mortality. Now, with that historical context, this leads us to the development of our research study. The purpose of this study is to understand the perspective of Black pregnant patients regarding the risks, benefits, and alternatives to labor pain management and anesthetic options for cesarean deliveries. Participants are Black pregnant patients in the antepartum and postpartum period who are at least 20 weeks gestation or within 6 months postpartum. We conducted semi-structured interviews, which had 8 different sections. The demographics of our study consisted of women between the ages of 17 to 42, 6 of who were primates, 5 of who were motips, and they range from the 2nd to 3rd trimester or were in postpartum. The transcripts were transcribed verbatim and analyzed using a thematic analysis approach. We are using an interactive coding process to identify emerging themes, and will continue this process until theoretic sufficiency is reached. This project is still ongoing. So far, we had the privilege of interviewing 11 participants, 9 of who were antepartum and 2 were postpartum. Preliminary themes that have emerged so far include secondary trauma, interest in culturally and racially concordant care, mistrust in the medical system, over-medicalization of birth, and dismissal of one's instincts and knowledge. When asked if you feel comfortable speaking with an anesthesiologist about your pain, secondary trauma is an emotional duress that results when an individual hears about the firsthand trauma experiences of another. When asked if you feel comfortable with an anesthesiologist about your pain, this antepartum participant responded. She didn't want a C-section, but the heart rate was dropping so fast that she had to get a C-section. And after she had the baby, they both were good, but then she started complaining about abdominal pain. And after that, she just went under and never came back. I don't want to have to go through anesthesia because I want to come back to my kids. That's the scary part. I don't want to think about anesthesiologists. I don't want to think about C-sections. This is just one quote, but many women shared how they have seen on social media or heard from family members or friends who have experienced trauma in the hospital setting and how that impacts the medical decisions they make. Over-medicalization of birth is the process of transforming normal physiological childbirth into a medical event where medical interventions and professionals become increasingly involved. When asked, have either you or your family's beliefs changed the way you think about managing your labor pain? This antepartum participant responded, at the beginning, when my friends weren't doing any epidurals, I said, oh, maybe I should do that too. Or maybe I shouldn't birth in a hospital setting, and that is a legitimate fear. I think also just being a Black woman and not wanting to be involved with the medical system, I want to be very mindful of that, mindful of where to deliver and the implications of being a Black woman in the hospital setting. Many women shared how they wanted as limited interventions as possible, and that they preferred to labor on their own the natural way before coming to the doctor or getting an epidural. Dismissal of one's instincts and knowledge is that someone's opinions, lived experiences, and innate knowledge about their own bodies are not valued. When asked, in this pregnancy or your prior pregnancies, have you ever felt like your pain or concerns were dismissed? This postpartum mother responded, definitely. It happens a lot as African-American women, but I guess because during that time it was my first pregnancy and I woke up and it felt mushy between my legs. I kept trying to tell the nurse, but the nurse took the epidural button from me because I guess she felt like I was pushing it too much. So she took it and restricted me from reaching it. I tried to get her attention by calling people in the hallway. And when she finally came in, she just basically was like, what now? And I said, oh, I think something's wrong. And so she told me, well, you never had a baby before, so how would you know? And I told her, well, because I feel something. And she had me push a little bit, and then her eyes got big. She ran out of the room, and it turns out that I was crowning. And that was my experience last time. And I just vowed if I ever have another kid, even though it was 14 years later, if I feel something, say something. If something isn't right, speak out about it. This is just one example how Black women have learned to be their own advocates since they often feel silenced, especially in the hospital setting. I wish that I could review more quotes, but these are just a few that I wanted to highlight today. So this is just preliminary data. We are still recruiting and interviewing participants. One consideration to improve the study is to interview antepartum patients primarily in the 3rd trimester, as participants at earlier gestational ages hadn't really thought about pain management yet. One recommendation is to follow up with the antepartum participants that we interviewed after delivery to see how their expectation of their pain compared with their actual delivery. In conclusion, I was very grateful for the opportunity to speak with these Black women and to learn from them. While I initially thought many participants would be adverse to the epidural, they actually were open to it despite the opinions of their family or friends. What was most important to them was the efficacy of the pain management option they were choosing and the impact it would have on their baby. Additionally, Black women are the experts of their bodies, and it is important for us to uphold a reproductive justice model in the care that we provide to our patients. Lastly, it is vital that we remember the historical context of how Black bodies are viewed and how that plays a role in the way patients may respond to how we counsel them and convey our recommendations. We can also prepare patients by talking to them in prenatal visits about their fears around childbirth in the hospital setting, so we can dismantle myths, create a new narrative, but more importantly, create a safe environment for people to share their birthing experiences with us. I want to thank you for your time and for everyone who helped me with this project. I want to especially thank, my family. This weekend, we celebrated my grandmother's 90th birthday. And I just would not be where I am today or who I am today without the wonderful women who helped raise me and support me. So thank you. I don't know if we have time for questions. But if you have any, I'm happy to answer them.
Excellent study. On your conclusion slide, and we sort of discussed it a little bit, just developing. It sounds like there is also a need for intervention with the providers. And this is, a big problem, a big question, but anything from your data that could help inform strategies for providers to be doing a better job.
The question was, from the conclusion, it seems like patient education is important, but also is there a role for interventions for providers? And I think absolutely. I think that as I've learned through my many years of residency, it's a life learning experience. And I think that we continue to learn the medicine, but I think that as new things develop, it's important to think about the history and how that plays a role. And so I don't know exactly what is the best way of the intervention for doctors, but I thought that today would be a great way to kind of share that history and kind of share this mission. And then hopefully from just today, the word will be spread just a little bit more so that people can, take that into account when we see our patients. And so one way is through presentations like this, and also just through the conversations that we have. I would say here at UCSF, we have a very unique experience in the residents that come here, and that we all are very mission driven. But I think that it will be interesting to see once we graduate what the rest of the world and other hospitals look like, and how we can better share this message so that we can better care for our patients.
Awesome. Well, Patrick always keeps us organized and on time. And it's my honor to introduce our final resident research day speaker, Dr. Shakkaura Kemet-Rosenwohl. She earned her Bachelor's of Art in Human Development and Regenerative Biology with a minor in African American Studies from Harvard University. She subsequently moved slightly west to New Haven, where she obtained her Master of Public Health with a focus in social determinants of health from Yale. Then she moved very far west to San Francisco, where she matriculated at UCSF. And before Dr. Kemet was a doctor, she was a powerful leader of her medical school community, receiving the gold-headed cane, an honor bestowed to only 3 students from each graduating class who exemplify the qualities of a true physician. We're exceptionally fortunate that she matched with us here. In residency, Dr. Kemet has been recognized with multiple teaching awards from medical students and co-residents and has been celebrated for her excellent surgical skills, organizational prowess, and effective leadership. But Dr. Kemet has a long-standing passion for being creative, writing, painting, and even hosting murder mystery dinner parties. Her writing has been a potent tool of expression. She has importantly utilized her strength in narrative medicine to uplift the voices of those often silenced, ignored, and excluded. And she has published multiple papers that have utilized qualitative strategies to highlight the experiences of others. And it is fitting that her resident scholarly work is centered around narrative medicine. I'll let her share more details of this work, but we are really thrilled for Dr. Kemet's future as an OB hospitalist and hope that she'll continue to use narrative medicine to reflect on the intense yet beautiful and powerful experiences of pregnancy and birth. Please join me in welcoming Dr. Kemet.
Okay, guys, we're almost there. Second stage labor, we're +2. There's no way out but through. Okay, we're gonna do it. All right, so I am Shakkaura Kemet-Rosenwohl, one of the chief residents. Thank you so much, Dr. Waxstone, for that introduction. I'm gonna talk to you about my narrative medicine project, where if you're a resident, you already know about it. Okay, everybody has the slide. We're type A, we know where we're going. It's there. Okay, what is narrative medicine? Great question. So narrative medicine is a discipline at the intersection of humanities, the arts, clinical care, and healthcare justice, and it's aimed at improving healthcare by helping clinicians understand patients' experiences and perspectives, the thought being that will then improve patient outcomes. And then when I learned about this, my thought was, what if we turn that compassion inward, right? What if we took all that energy that we take to understand patients, to understand ourselves, and if we do that, do we improve our outcomes as physicians? And the outcome I care about is burnout. And if you haven't heard about it, it is a huge issue in medicine in general, but specifically in our specialty. A recent survey found that our burnout rate is somewhere between 40 and 70%, depending on where you survey people in their career spans. One of the biggest inflection points actually being residency and early career. And right after graduation, we have a couple of studies that say it's more like 75%. Okay. And if you want to know us compared to other specialties, we're right up there with like ED and trauma medicine, high stakes, big decisions to make all the time with huge impacts on multiple patients. So what is burnout? So burnout, as defined by the American Medical Association, is a long-term stress reaction that can include emotional exhaustion, depersonalization, lack of empathy towards patients, and a feeling of decreased personal achievement. And then resilience, I'm going to define that for you as well. So there are a lot of different definitions, but this one I like the best. It comes from a meta-analysis of 9 different qualitative papers that are all asking physicians in different practice settings around the world, different specialties, like if you had to define resilience for yourself and how it works for you in your practice, what does it look like? And they say having tenacity, supportive institutional culture, professional boundaries, work-life balance, reflective ability, and growth in the workplace, despite the inherent challenges of being a physician and working in medicine. And if you're a picture person like me, this is actually the pictograph that they use to take all those concepts and put them together in their paper. And my thought was that narrative medicine is probably going to intervene here, right? Reflective ability. Narrative medicine is all about being able to take time to reflect on your experiences and grow from them. And if we intervene there, then maybe we could affect the way that residents cope and the way that they grow in residency. This is the amazing team that was part of my project. Many of them need no introduction. In fact, many of them have been up here already. But I wanted to talk about Dr. Ashley McMullen because she's probably not someone you know as well, but was a big part of this project. She's an internal medicine physician and does a lot of the narrative medicine work that's actually part of the internal medicine curriculum here. So what did we actually do? We had 2 residency-wide narrative medicine events, and residents were given protected time to go engage with either an art or a reading, and then to talk about identity formation in the setting of diversity. And part of that, after we engaged with the art or reading, was to then do individual reflection and then group reflection with prompts and small group discussions, and then I sent out a Qualtrics survey. The first event, just to give you an example of what we do, was that we went to the SF MoMA. This happened much earlier in the year, if you recall, on a Teaching Tuesday. And this was an exhibit done by a South African visual artist, an activist who has an LGBT identity, and the exhibit examines that. And then the way that we structured this, the real workhorse in this project for getting to connect the art or the reading with the outcome that we care about, right? Reflexive ability were these facilitator guides. So our team worked really hard before events to create these guides. In addition to like figuring out the mechanics of getting 30 residents in and out of the hospital in 3 hours, it also helps you to figure out like what kinds of questions we're going to ask to get residents to reflect, to get people to really work on that reflexive ability muscle. And then these are the surveys that I made. So short, 5 minutes, Likert scales, right? Make it easy for people who are really busy. And then an optional subjective box at the bottom to do qualitative work too. And this is my data. It's pulled directly from Qualtrics because I still really only know how to use Excel for clinic prep. And I know this N of 23, that reviewer number 3 is out there and you're like, only 23 people. What are you doing? But for a residency of 40, which is my total group, people are on away rotations, on vacation, sick, whatever. This is actually about a 75% response rate from a total N of 30, which is what we had. So thank you so much to my co-residents for responding to my survey. And then to give you broad sweeps of what this data is looking at. So your red and your dark blue are either strongly agree or agreeing with statements. And the statements I'm asking are directly geared to 2 real big things. So 1, did you feel safe to engage in this work? And 2, if you did it feel like you were able to reflect on things that are revolving around identity and minority identity specifically for the first event, because that was what we centered on. Then some of the qualitative data, I will let you guys read these for yourselves while I talk, but basically they're talking about people really wanting more of these events, feeling very fortunate to get to do this in residency because it's not a traditional part of residency training, and then also cementing that connection between the event that we did and feeling they had a chance to talk about identity formation. Second event was a reading. This happened at resident retreat, and this was about an ER physician delivering a baby, his experience with that, and then also a parable that was kind of about finding meaning in work and it being a very intentional thing that we do. Another facilitator guide, very similar structure, right? Making sure that people who are facilitating these groups have the questions they need to ask that are going to get the outcomes that we care about. And then another survey looked very similar to the previous one. And then again, you see similar trends in data. So most people strongly agreeing that this safe space was created for them. And then a little bit more mixed data about finding meaning in work, feeling like they had a safe space to do that, feeling that that's something that this event helped them to do. So conclusions, I think for this work, what I really was trying to do was 1, really clearly figure out if we had a safe space to do this. I think if you're asking people for vulnerability in a workplace, you have to be sure that you're creating a space where it's safe to do that, or else it's not ethical to do it. So to make a foundation to do this, I think we can say that overall people felt like this was a safe space in which to do this kind of work. And the second thing is like the main basis of my hypothesis, right? Do these narrative medicine events actually get people to work on reflective ability? And I think that also this data helps. For strengths, I really could not have done this project without the residency leadership support, giving us protected time to have these events. And then, like I said before, and when I reviewed the literature on narrative medicine, I really could not find any other projects that have a provider-facing lens. I think that's new and innovative. For limitations, selection bias always for survey responses. And then another thing I think is like I defined it for you here the way I think about it, but resilience and burnout are very amorphous terms. They're hard to define, many influencing factors, therefore making it super hard to study. And then we don't have any long-term data yet on an event that we know or a concept that we know affects us across the career span. And then I wanted to really take a moment to talk about a common question that comes up when I talk about this kind of work, because I think it questions some of the assumptions that we make in medical practice. And people will hear me talk about this and go, well, Shakkaura, people have successfully completed residency when it was harder than it is now, and they are good doctors. So even if burnout is real and affecting us, why change, right? Why take protected time out of a very short residency to do this? And my answer basically is that whenever you settle for what essentially is already existing, you don't get what you could best, we get is best, right? Like this is why we see UCSF, we redefine what's possible, right? The whole premise is that you don't get the best outcome when you just settle for what is. And then hidden in this question, I think also is a perceived lack of respect or gratefulness for what was endured or fought for before me to create my 80-hour work week restriction, right? And I want to say that if my ancestors had settled for what's possible, I would not be here. And as a Black woman, I can hold respect for the hard path that was walked before me to make me possible, be grateful for what I have, and also have a responsibility to make it easier for those who come behind me. Okay, previous success under harsh conditions is not a reason to keep them. We owe it to the people who train in this field to make this not just survivable, but something you can thrive in. And then lastly, I want to give a little gift to my co-residents, both past and current. This is my favorite quote from my favorite Toni Morrison book, "You Are Your Best Thing." It's from Beloved. And interestingly, it was pulled to create the title of another book about resilience by Tarana Burke and Brene Brown, which if you haven't read it, you should. And basically, I just want to say, you are your best thing. Before you get up in the morning and you answer the consult call, you cure the cancer, deliver the baby, whatever it is, you are your best thing, and you deserve to be well in residency because you exist. Okay. I will take questions for 1 minute.
Study and presentation, and I hate to disrupt people.
No, it's okay. It's okay.
Question. And so in residency, there is dedicated protected time for learning, and it's incredible that important that this is made. But once you graduate, when there's still lots of chance for burnout, protected time is it's
non-existent.
It's a humble, and if you, yeah. So in terms thinking of reproducibility, and I know you haven't finished residency yet, but any thoughts or hypotheses about how something like this could be
Yeah, the question was about having protected time to be able to do this, noting that we don't have protected time after residency for these kinds of things or really anything, and how to make this reproducible. So I think, well, to be honest, their ACGME actually requires that we dedicate time to the wellness of residents. I was digging through their guidelines when I was doing this presentation. There is actually a huge paragraph about the psychological well-being of residents being important to their professional development. So I think we have the onus, we just don't recognize it, that we have to give people tools in residency to be able to succeed outside of it when there is no more protective time and you just have the tools you were given in those 4 short years. These should be some of the tools that we have. To answer your question. Okay.
And let's give a big round of applause to all our fourth year chiefs. Dr. Cook giving a standing ovation. Congratulations, your presentations were fabulous. They really fused the ethos of who you are and what you care about, and it's beautiful to see you share that, so thank you for doing so. They also were as diverse and varied as you all are as individuals, and so it's beautiful to see the collection. Know how proud we are of you and of the incredible work that you have done. And with that, we'll conclude Resident Research Day. Again, a big extension of gratitude to Dr. Suffren for sharing how her work has really transformed conversations and our specialty, and to our staff, Patrick, Mary Beth, and Alexis for everything they do. Hope you have a beautiful day.